Okay, we'll get started. Welcome, everybody. For those of you who want to learn about the real world of how to apply data in the clinical environment, interacting with patients and everywhere else in healthcare, this is the session for you. We're hearing a lot about AI and big data and machine learning. None of it's worth anything if we can't make it actionable in the real clinical environment. This group today are the people that are trying to figure out how to do that. And I will tell you it's under very difficult circumstance because technology has been a challenge to adopt in the clinical environment, as we all know. We all hear about clinical burnout. And that is because technology hasn't necessarily worked the way we had hoped in terms of systematizing medicine, making it measurable, and making the lives of those using the technology better, not worse. These people are the ones that are trying to make technology systematize medicine, make technology work for the clinicians and the patients in ways that they will like and not resist, and make all of this knowledge that we are gaining actionable in the clinical workflow. Our challenge is that the volume, velocity, and veracity of data is increasing, as we know, by the minute. And we're a dog chasing a truck because we get this data in one place, but we simply can't use it. So the only way to make it useful is within workflows that humans can function within. And what you're going to hear about today are the people at various health systems, I'm happy to say, not just partners, who are fighting these battles and winning to make data and workflow bring systemization to care to help drive down cost and improve outcomes. So with that, I'll turn it over to Alistair Erskine, the moderator, and thank you all for coming.
Thanks, Steve. Welcome, everybody. This should be a fun and interesting panel and discussion. My name is Alistair Erskine. I'm the Chief Digital Health Officer at Partners Healthcare. I'm also a pediatrician and internal medicine physician. And what I'll do is I'm going to let each panel member introduce themselves, and then we'll get started.
Great. So I'm Mike Anderes. I have two roles. I'm the Chief Innovation and Digital Officer at an academic medical center in Milwaukee called Froedtert and the Medical College of Wisconsin. It's a pretty high-performing but not well-pronounced medical center. And about 4 years ago, we also decided to get serious about some of this work and spun off a separate company to try to accelerate the adoption of digital. And I'm the president of that organization.
Hi, I'm Aimee Quirk. I'm the CEO of innovationOchsner, which, similar to Inception, is a company that Ochsner Health System started about 4 years ago. Ochsner is the largest nonprofit provider of healthcare services in Louisiana and the Gulf South. And we started IO to help accelerate and incubate new ideas in digital and beyond to revolutionize healthcare. So we're focused on transformational strategies to improve the experience for everyone, to obviously improve outcomes and reduce costs.
Thank you. My name is Zane. I'm the Chief Innovation Officer for University of Colorado Health. Colorado is a square state, a little bit west of here. I'm also the chair of the Department of Emergency Medicine and a professor at the medical school and professor at the business school. My role as Chief Innovation Officer is really to form and lead a team that looks at ethnographically identifying pain points in our healthcare system, partnering with external partners around technology and digital health to very specifically solve those pain points and sometimes invest in those companies.
Hi, good afternoon. My name is Adam Landman, and similar to others, I also wear multiple hats. I'm an emergency physician at Brigham and Women's Hospital. I'm here in Boston and part of the Partners Healthcare System. I'm also the Chief Information Officer for the Brigham, and so responsible for the day-to-day operation of our clinical and other information systems. And then finally, I also oversee the Brigham Digital Innovation Hub, or iHub, which is our arm, similar to others on the panel, which is looking to help transform the Brigham with digital solutions.
Well, thank you very much. And I thought, probably a good way to start this panel was to just tell a little bit of a story. And so many of us go around and look at the clinical workflow, since that's kind of a lot of what we're steeped in. And in fact, every Friday, that's what I do from a practice standpoint in terms of informatics. And I want to share with you a story of just one example, and each one of us have many similar examples of what I see. So if you walk into an endocrine clinic and go to the person at the desk that greets the patients, in this particular clinic, I noticed that there were 10 little icons on the desktop. And each icon was represented by a different vendor for the glucometers that the patients were bringing in. And the workflow, as I observed what was going on, involved the patient handing the glucometer over to the clerk at the desk, using a USB to be able to download the information onto that specific computer, then printing that out on a printer, then taking that piece of paper, going to a scanner, scanning it into the electronic health record. I should say, scanning into the scanned images part of the electronic health record. And then, a week later, the physician sitting in the office taking that information from the scanned health record and typing it into her note to be able to be now a discrete component of the record. I just bring that up to say that even though the technology exists, and even though the workflows have been kind of carefully titrated over time, you still find at the point of care where what is in our minds in terms of what actually happens and the reality and boots on the ground, there's a bit of a cognitive dissonance. And this occurs in the context of $36 billion worth of funds that went to fund electronic health records, the $8 billion a year that go towards digital health technologies last year in 2018 that was spent in terms of trying to improve our digital health assets across the country. And even at Partners, the $1.2 billion that was spent on Epic. And so the question ends up being, with all that investment, are we better off today? And if we're not, how can we end up improving how this translates into helping patients and how this translates into helping clinicians take care of those patients? And I think, you can think of it as sort of categorizing, and we'll go into some description as to what health IT really ends up being, but you can categorize into now some things that are just basically table stakes. The things that a lot of us have implemented and we figured out what works and what doesn't work. And so there's certain things that there's not a lot of debate about being able to do. And I would put that into the category of things like login and secure text in and turn on features within your electronic health records. And there's some other sort of obvious next things, and we'll kind of get into some of that. There's also this kind of a category of things which are just vexing legacy technologies that just won't die, things like pagers and fax machines and telephones and CD-ROMs. You can't even buy a CD-ROM on a computer anymore, yet that's kind of how we do it. So for some reason that sort of stays persistent within applications. And then there's a ton of headwinds that exist right now. Headwinds in terms of as we kind of bring these technologies to life in a clinical workflow, whether it's the impact of consumerism that is coming along, or the fact that there are regulatory mandates that have unintended consequences, or the fact that things are digital, and so now all the cybersecurity nefarious players try to find ways to gain access to it. All those add to the fragmentation and also this insatiable appetite that AI is dependent upon to be able to actually create good models. I want to kick off a question to the panel before we kind of get into the, what exactly let's define why we're going forward with digital health. What is it that it compels us to kind of continue to drive forward, to continue to invest? And maybe, Rich, I'll turn to you for some of your thoughts.
So I guess the short answer is the reason why we're going full on into digital health is because we suck. And that's the truth. If you think about healthcare delivery now, medical errors are the third leading cause of death in the United States. If you enter healthcare in any way, shape, or form, just touching healthcare, you have the same injury profile as bungee jumping. If you get prescribed a medication, there's a 25% chance that medication is going to hurt you, 50% chance the medication is not going to do anything, and a 25% chance that it'll help you. So the bottom line is we need to make better decisions. So when I think about digital health, I think about intelligence. And intelligence just really means how can we use technology to help patients and providers make better decisions about healthcare. Everything from how do we educate a large group of healthcare providers, how do we pick the right pharmacotherapy, how do we make sure that patients are getting guideline compliant care? Because right now, without digital health, there's a 1 in 5 chance that you get guideline compliant care. So that's really the overarching theme. We need to make better decisions and we need to do better for our patients, and that's why we have to embrace digital health.
Adam, the why?
So amplifying what Rich's comments were, I would say it's about the quadruple aim in healthcare. You know, we're fundamentally trying to improve health, improve quality and safety, improve efficiency, and importantly, improve the clinician experience. We need to be careful with that. With previous technology initiatives, we have caused unintended consequences of increasing the administrative burden for our clinicians, and so we need to be particularly mindful for the last component. And just a final comment, I'll just paraphrase a comment from a colleague, Dr. Ashish Jha from the Harvard School of Public Health, and he said it really nicely. We're not really talking about digital health here, we're talking about health. This is the future of health, and digital is just going to be a component of everything we do in healthcare going forward.
I would say amen to both of those, and I would just add that I think part of the promise of digital health is it has the power to empower patients in their own health and make them more on an equal footing with their caregivers, with their physicians and other caregivers, so that they understand what's going on. They understand that the decisions that they make at home in their everyday lives, how that's impacting their health. And to help us shift from this historically paternalistic model that we've had that is not working, and we've got a lot of work to do, particularly in the area of chronic disease. How can we kind of shift that paradigm where 86% of healthcare costs, 75% of deaths are resulting from chronic disease, and the problem is just growing, yet we're not really tapped into our patients' lives in between visits. Well, digital health gives us that chance to do it and to make partners out of our patients in their care. And so I think that's part of the promise of digital health and why we're pursuing it so hard at Ochsner.
You know, I think for us, you'll hear common threads up here, I imagine, more than once. But we took a step back and said a few years ago, like, what are we actually trying to become? So we were very intentional about saying that, you know, we need to be much better at being personalized. We need to rethink access and make sure that it's not this transactional sort of flow, but it's more of a utility that's always on, so a 24/7 approach. And we need to dramatically lower the cost of care, and that's the cost to provide it, but also the cost that we pass along. And while doing all that, we have to make sure that we bring joy to practice back. And we just see digital as a tool to enable all of that, and frankly, all of that is not possible without digital. So we kind of started with, you know, what's that vision, and then we backed into how are we actually going to accomplish it.
So we've already made some ground in this panel. We have a new motto now: "We suck less" is really what we're trying to get after.
True.
And you know, and it's going to be little d, big H for digital health. I think that's kind of a reasonable. So in this looking forward at where the puck is going, is there a portfolio, a typical portfolio that you get when it comes to digital health? What are the components that you know? What's part of the playbook in terms of things that make sense that would actually help bring joy back to medicine?
I'm gonna say that I don't think there's a standard portfolio, but I do think, you know, one of the things that we would take from that vision and then make sort of the next step down would be what capabilities do you have to have? And one of the hard things about healthcare is that there's a lot of customers out there. And I think those capabilities resonate differently depending on who you're talking about as a customer. So for us, if you think of the patient or the consumer as the primary customer, then they want engagement, they want access, they want personalization, they want things that are going to be capabilities that allow that to be accomplished. But if you talk about employers and payers, they want things that are going to be more related to population health management capabilities. And then finally, our workforce in general, I'd say it's providers, staff, back office. They want administrative burden reduced. They want automation. And so we've taken an approach to try to say, all right, which capabilities do we need for each one of those? And you can imagine for consumer engagement, of course, you need a robust CRM. And for some of our transactions, you need a good transaction engine, and you can say your EMR is one of those, or you could have additional tools. But then, even if you've got that framework, you still have this challenge of there being too many choices out there. And I think that sort of process for us has been about a balancing act. So we think of the supply of all those capabilities coming from 4 different areas. And I think those areas are different depending on which institution you work at, especially after being here for the last day. One area is homegrown, like what can you actually build on your own? Where we live and with the resources we have, we're not able to do that at a great sort of degree of scale. When you go though and look at the entrepreneurial community, the startup community, there's a lot of noise out there, but there's also some very potentially impactful tools. And then we've all invested in an EMR, so that's your third sort of source of potential digital kind of capabilities. And then the final one is we put a fair amount of attention to what we call AAA, so Apple, Amazon, and Alphabet, because we do believe they're very serious about making a difference in healthcare in their own different way. And they, frankly, command an amazing amount of consumer engagement and consumer loyalty. So I think our job in a portfolio is to figure out how to define which capabilities are important and then figure out where we're going to get them from, somehow balancing those 4 different sources.
Aimee, you run I/O, which is innovationOchsner. How would you approach that kind of portfolio?
Well, I think, I don't know that there's your question if there's a playbook per se. If there's one, we've not found it. But a couple of things that I think are just ground rules that when we think about our portfolio is one, remember why we're doing it. And that matters so much at the end of the day when we are selling it, trying to test something that we've created or want to bring in to our colleagues around our system, to our patients. We're here to make things better for our patients, for the caregivers, and we just need to remember that. And the second thing that's part of what we do is we act. And that, I think, is part of this group up here is we are all doing something. And I think that's part of the magic of this is that we are in a space where we're learning there's this unprecedented investment in digital health, as Alistair mentioned, and there's a lot of work going on, whether it's having the intended impact of advancing the quadruple aim yet. I don't know, and I think most people would say no. But what we do know is that we're learning, and we've got to act quickly to get there. Because the problems, there's so many pain points that we're experiencing every day. We know it because it's a human experience. And so you've got to start. And so some of the things that we've done, and as we approach how do we start, is one is we follow this Everett Rogers diffusion of innovation and go to those early adopters and innovators, and you can find them. They're there. They're ready to adopt things. They are looking out there. Steve calls them the pirates, and we look for them when we're ready to launch something. And that's something that I think is critical. And every initiative that we've had that's been successful, that we've been able to scale, which is really the hard part of innovation, I think, is because we went through this deliberate process of really going to the early adopters first. So, and then the other thing on the portfolio is there are a lot of problems, a lot of areas, everything from access, which is a big issue everywhere, and the equity of that access is a big issue everywhere, all the way down to the care and some of the things Rich was mentioning about the care variation and the lack of consistency that we see in the quality of care, notwithstanding that we've got such great professionals in this country. So I think we are balancing out our work between those clinical areas as well as business areas. There's a lot of back-of-house things that new data practices and technology can help us solve. And so we're managing that, because the fact of the matter is the ROI on some of these things is slow or unknown. And we try to have a balanced portfolio approach to get some wins more quickly while we're kind of taking those big swings.
So this is less like an ERP kind of system where you can go off the shelf and pick something off. And it's much more what the common term is used of, sort of building the engine while the plane is still in flight. You finding those pirates at your organization, Rich, in terms of, as you think of decision support tools and what you're doing in terms of care redesign?
I think I am a pirate. I think that when UCHealth, myself, looks at innovation, we try and remember what our lane is and what our lane is not. After being a father and a son and a husband, I really view the world through the lens of a physician. I take care of patients, even if I spend 80% of my time administrating and only 20% of my time taking care of patients. When I administrate, when I think about innovation, I think about it through the lens of a healthcare provider. So we are very pragmatic in our approach, which means we identify what these pain points are. Where is there not an off-the-shelf solution? And if there's no off-the-shelf solution, we need to partner with someone to build the solution. And when we do that, we don't look internally, really, at developers internally. We look externally, because there's a different cadence in the world outside of academic medicine. There's a cadence of not 7 to 10 years for a solution. There's not a 20-year turnaround for technology. This is quarter to quarter, day to day, month to month. There are people who, if they don't get it done by the 6 months, they run out of money. We like that cadence. We think we have a lot to offer. We think that by understanding healthcare, by being able to socialize technologists and entrepreneurs into how providers think, that we together can build much better solutions. And that's really what we've tried to do. Look for those pain points, build those solutions. Don't build them just for us. Build them for customers number 2 through 600. And we've had some wins and we've had some spectacular fails, but it's been interesting being a pirate.
And Adam, are you finding that difference between the cadence in iHub, Brigham's Innovation Center, and the cadence at the enterprise, and how do you reconcile the two?
Yeah, as you know, there is some tension there, healthy tension, as we push each other. I think the way we've tried to approach this is that we first try to start with, if there is an enterprise solution, so particularly if our EHR vendor has a solution, we will try to use that solution. If there is no solution from an EHR vendor, we will look towards companies on the market, do a market scan, and understand if those companies have a solution that we can just purchase off the shelf. And those are ways that we can act very nimbly and quickly, because we're leveraging either technology we already own through our EHR or a product that already exists. Oftentimes, as we are all in this room, really ahead of the curve, there may not be a product that exists or a product that meets our needs. And so then we will look towards companies that maybe have similar feelings to us as where the product may want to go, and work to co-develop the product with them to try to get the product to meet our needs, which we then think will meet the larger needs of the marketplace. And then there are some circumstances where there just isn't a product out there, there's not a company out there that's doing it, and we will look to actually build that ourselves. And as I was talking with Mike about and learned yesterday, another strategy there is we look to build it ourselves, but then potentially find a partner to commercialize that and move that outside of us so that it can be really maintained by a group that's dedicated to that software. I think the biggest challenge for us, as Aimee was getting at, is really where to focus. There are so many opportunities. One of the ways we've tried to solve this is to look towards our institution's strategic objectives and see which of those strategic objectives we can help solve. And we've narrowed it to 2 or 3 of those to focus on in any given period of time.
Thank you. So let's get more specific about, now we We understand that there's a need to prioritize the different approaches that can be taken in terms of whether to build, buy, or co-develop, and look external to the healthcare environment for ideas that can be applicable to healthcare. But if you had to pick 3 of sort of the top things that you're working on right now that you're trying to sort out, what would those be? Mike, do you want to start us off?
Yeah, and again, I'll kind of talk about them in terms of capabilities, and then maybe if you want to hear more about specifics, I can share that. But access is a huge imperative for us right now. So anything that we can allow somebody to self-service is kind of top of mind. So that, I know it sounds simple, but just allowing people to schedule an appointment is painful, no matter what tool you're using. But also to even maybe figure out what you need, and we use in that sort of category of self-service tools that allow patients to check their symptoms and then determine what's the best course of treatment. So that's sort of one bucket. The second is we are trying to keep people out of our hospitals. So we are trying to keep people at home, especially those with chronic disease. So we're amping up our remote monitoring capabilities, especially around a few specific diseases. And then I'd say the final thing is we're really, although we don't have a great story to tell yet, we are trying to be much more intentional about bringing some of the personalization into the exam room or into the equation. So bringing in personal preferences through some software that we're co-developed, and also bringing in biology. So your genomic data where we think we can actually provide value to create a bit more of a holistic picture of that individual who's in front of that provider at that time. So those are kind of the 3, I think.
And I wonder if we're going to end up having similar answers. But Aimee.
Yeah, so one of our top priorities is enabling care in the home and keeping patients living their best lives. And so we are focused on chronic disease as one area where we have built a remote monitoring platform within leveraging our EHR, but also creating a care team to work with the PCP and help support those programs. We have programs live in hypertension and diabetes now, and those have demonstrated results in terms of patient satisfaction, sustained clinical outcomes, and reduced costs. And so we are adding more conditions to that platform. Even outside of chronic disease, we've gotten into pregnancy as well. And so that's something that we are very focused on, have been for some time now, but are doubling down on that. As well as what other sort of additional in-home assets can we provide and support can we provide to our patients, again, because we know that they are going to be living their best lives at home, and that helps contain cost and create a better experience for everybody. We, at the same time, are focused on trying to make hospital care better. We've used some AI, we can talk about that later, as well as other technology tools and just basic workflow changes to make the hospital experience less disempowering, which it totally is, and more healing. And so, if you do need to come in, we want to get you out as quickly as possible, and we've had some success in reducing length of stay and readmissions through these types of tools. And then ultimately, I think, similar to Mike as well, is the journey on personalized health, and really taking a broad view of our patients, going into all the social determinants of health. And that includes certainly the genomic side, but also collecting environmental information, which we are doing right now, and getting into all of those behavioral and social pieces as well. And so that's a big area of focus for us. So a lot of similarities there.
I think you'll find similarities across all of us up here. We've really focused, again, on intelligence and making better decisions. Whatever remote monitoring means to different people. Remote monitoring could mean I'm putting a patch on you or in you and getting data off of that device. It could also mean that I'm watching how often you go to Starbucks, because if you go to Starbucks 7 times a week and all of a sudden you're going once a week, something has happened to you. How we take that remote monitoring and how we integrate it into our data capabilities and how we use that to build prescriptive intelligence is really what we've been focusing on. So we all have clinical data We all have some access to claims data. We may have access to genomic data, physiologic data, waveform data, and then social data. How do we put all of those together to make better decisions? An example would be, the single most identifiable confounding variable associated with readmission for heart failure is your credit score. Right? Not anything about your heart failure, but it's your credit score. So how can we take thinking like that to let us make better decisions about who can be cared for at home, who does not need to be in the hospital? Because there is no one formulaic approach to any singular patient. We have to know what their home looks like. We have to know whether they have family or assistance. We have to know what they look like, maybe not second to second, but maybe minute to minute. So when we think about virtual health, that's how we're thinking about it. Not just acute, episodic, and unscheduled care, but the entire spectrum. From ICU care to virtual surveillance, so looking at patients who are in the hospital to see if we can predict when they're going to get sick so we can intervene sooner before they get sick. And the same applies to patients who are at home. Because I can build a hospital at home. That's not hard. It's hardware and capital and people. But can I really monitor patients in their home to predict when they are at risk? Can I look at the kid who's using his or her inhaler 6 times instead of twice, intervene on that day and prevent an emergency department visit and an admission? Can I tell that when a patient who has heart failure gets up 3 times a night instead of 2 times a night, intervene then? That's really where the secret sauce, I think, is going to be, is this integrating whatever monitoring means and making prescriptive decisions, allowing humans to make human decisions and allowing machines to make the decisions they can make.
Rich, let me just double click on the issue of personalization. As you're saying, a lot of monitoring that needs to occur in order to be able to have a good sense as to who's at risk. Even extra healthcare type of information like FICO scores. And I bring up this example in terms of how does personalization and privacy work with each other? We've been in a situation where there's some FCC laws that make it difficult to text patients without their consent. Therefore, you can't text a patient if it's okay to text them.
Yeah.
Because you can't send the initial. So, that's some of the things we stumble across in terms of just, as the various different laws are trying to protect patients from being overwhelmed with technologies, yet we want to get out there and help them and identify when they're going to be at risk. Are you running into that kind of tension?
Adam and I just had a similar conversation to this. And one overarching theme is that I think that lawyers are really great at identifying problems.
You're next to one, just
right?
so you.
Yeah, I don't tell anybody that, particularly in a medical conference.
Whenever someone identifies a problem to me, I ask them, what are the 3 possible solutions for the problem you've identified? Right. If you identify a problem like an FCC law that you can't text patients, what's the solution? Thank you for identifying that problem. I want a solution. So we have a solution. And we essentially made an app that is the UCHealth app. Every single thing that's patient-facing goes through the app. All of our providers, when they communicate with patients, communicate through our portal, which means that the first time that you encounter a patient, they've given us permission to contact them. They've also given us permission to monitor them. So whether they're wearing an Apple Watch or a Fitbit or a Google Home device, they've given us permission to do that. They've given us permission to sample their genome, and we've done that on a very personal level, but we came with a solution. It's very easy to identify those kinds of problems.
Adam, what are sort of some of the top things that you're thinking about?
So it's interesting working on many of the same things: patient experience, access, capacity management, flow. So I echo everything that's been said. What I think as I'm sitting here listening to this is we are all working on the same stuff, but this is very different than the EHR world, where you go out and you purchase a package for an EHR, and there's a very clear script on how to implement this. I think, I know, and based on all of us, we're all approaching these problems differently, using different software packages, some different vendors, and so I think that's what's making this field particularly challenging, is there is not an easy one-off solution where we can just purchase it, implement it, and we're kind of done. This very much requires what I think you're hearing from each of us, this agile environment where we understand what the needs are, we test things to figure out what works, and then when we find the things that work, we scale them. When we find things that aren't working because of workflow, cost, or other issues, we actually just move on and go to the next problem. So I think it just requires a very different approach than we traditionally take with health IT and EHR systems.
Okay, that's very helpful. So I keep hearing this recurrent theme of no playbook, no off-the-shelf product, the need to innovate, the need to be able to have some tolerance for some failures as we kind of continue to kind of chart the course going forward. So we've heard a lot at this conference about artificial intelligence. And all the dimensions that exist in terms of where it's applicable, what kind of data does it need, some of the sort of unintended consequences that occur. So can you provide specific examples in your organizations where you're seeing artificial intelligence actually deliver on the promise, and maybe also where you're seeing that the promise wasn't actually delivered?
Yeah, I can take a shot at that, and I will preface this with, and I think Jensen from NVIDIA said this well yesterday, that software is basically a way to automate things, and I think his version was AI is software that writes software, or software that automates software. And I think we are still at that first phase of we still need to automate things through basic software. So some of the things that we're doing, I would say, are laying the groundwork for that next layer of software to actually improve it. But you can see it throughout our organization. So if you look at things as boring as revenue cycle in the sort of corporate back office, we've been able to use software and robotic process automation and other things to basically eliminate people that have to touch things. Not super sexy, but it reduced cost and shows that there's value in these things. When we move into the clinical side, on the inpatient side, one of the things that we've done recently is instituted remote monitoring software for all of our inpatients that pulls about 320 different data points every minute around a patient to give a score, which by itself isn't AI. I mean, the algorithm, I think, is relatively fixed. But then we centralize the monitoring of that, so we then have humans that are, which again, right now we have to have humans doing this sort of QA work on this and then intervening when there's an intervention that's needed. But that process of actually centralizing and looking across acuity of all of our beds across multiple sites, I think gives us then the groundwork to try to automate that in the future. And then on the patient-facing side, symptom checking we're doing right now through, I think, what you could call AI. It was actually a company, I think it was developed in this area. And we're experimenting with it. We have some early data that patients really like it, and they use it at times of day when we're not available and for conditions they may not be comfortable talking to their physician about. So that's sort of an interesting signal. And then we have things sprinkled in between those. But I think it's sort of everything from consumer engagement on the front end to kind of back office corporate is sort of the smattering of things we're doing right now.
So I'm reminded by a tool called Eliza back in the early 2000s. And Eliza would make phone calls to patients in their home and would ask them questions. And one of the sort of aha moments was patients were much more willing to divulge information to Eliza that had sort of this humanized voice than they were to their own physician. So it's sort of interesting. So how is AI having an impact at Ochsner?
So we have used it in a few different use cases, both on the business setting, as Mike talked about, and in the clinical setting as well. And one of our recent use cases was around predicting codes on the floor. Some of you may be familiar with the Muse model, which gives a 60-day advance warning of who might deteriorate, and the specificity of that and sensitivity of that model is just over 50%. I mean, it's not that helpful to really be able to tell what might happen. So we set about, our team developed a model and trained it on about 125,000 patient records, and then validated it on another 200,000 to predict patient codes on the floor. And This is important work because, for example, if a cardiac arrest in the hospital, the mortality rate for that is 75%. That's a big number, and if we can be able to prevent events like that by using machine learning techniques and the interventions that go with it, we can have a big impact on our patients' lives. And so we developed the model and launched it and developed an intervention where doctors would receive the rapid response team rather than who would normally go in after the fact when a patient had coded and to resuscitate them and transfer them to ICU. We created a model that notified doctors on their smartphones, or their Apple Watches, about patient room 402 has an 80% chance of deterioration, and you've got 4 hours to get in there and figure out what's going on. So they go in there with more of the diagnostic mindset to prevent the code. And in our pilot, it was very successful. We were able to reduce codes by 44%. And that's a really impactful example of, I think, what we can do with some of the data that is available to us to make a real impact on our patients. What we're finding, though, and you ask kind of where is it working well and where it isn't, is that the intervention part is hard. How do you maintain that and make sure that all of those responses are happening timely? Are people trusting the model? Those are kind of the ongoing challenges to embracing these new technologies that when you're really bringing it to the ground and you're bringing it to the bedside, that you've got to stay on. And so this idea, and this came up a couple times yesterday, is that the implementation and monitoring of these models over time is a challenge and something that we're always going to be working for.
Rich, in terms of AI making better decisions?
So we've had two opposite end of the spectrum experiences I can tell you about. One is we have something called Patient Line, which is every hospital system has the same thing. It's an interface for patients to call and get whatever question they have answered. We have about 110 people who do nothing but answer these calls. We noticed that half of these calls were not questions that required a human to adjudicate an answer. So we worked with a company that does the bot development for Home Depot and United Airlines, and we essentially created our own bot to be that first interface. So 30% of the calls that come in now do not need a human to answer that call. And AI, it's just pattern recognition. So just look at all the things that we've done. What is the same pattern? Get it all the way down the pattern until you have to inject a human in. So that's a high-tech solution to a low-tech problem. On the other end of the spectrum, we have the only NCI-designated cancer center in that entire region of the country. So we get a lot of patients who get referred to us with acute leukemia. And what I've come to learn is that survival from acute leukemia is bad, and it's directly correlative to the success of your first encounter with a chemotherapeutic agent. When you get through the NCI guidelines for leukemia, picking the first chemotherapeutic option for a patient is left to oncologist discretion and intuition. It's actually written there. So working with a very large payer, working with our Health Data Compass, which is our data warehouse, working with a genomics company, we were able to ingest genomic information from the patient, so what's the genome of their cancer, bring our clinical data set together with claims data, and think about a learning algorithm to pick a chemotherapeutic agent. Now, if you were doing an NIH multi-center trial, this would be a 20-year gig or a 10-year gig. In 3 months, we identified 17% of our patients who should not get one category of chemotherapeutic agent. So that's just in 3 months. So if we allow that to continue, AI is going to significantly improve the outcome of our leukemia patients.
Okay. So you're hearing about many of the incredibly exciting AI applications at Brigham, MGH, and partners across the forum. I would say in production use, much of our AI as Mike was sort of alluding to, we are still very much on, are we digitizing data entirely and starting to make appropriate use of rules-based AI? And I'll give you a powerful example, and this was done in conjunction with an early stage startup that has now been acquired by a larger software development services organization. And the challenge came from, this was a capacity management problem. It came from our chief medical officer who was working to improve throughput in the emergency department and across the hospital setting. And he noticed that there was a delay in admitting patients that had flu-like symptoms. And the reason for that delay is that those patients require an isolation room. As you can imagine, it's difficult to get a single patient room in a hospital that's quite full. It's much easier to have a shared room. And these patients, per infection control best practices, they have to stay on isolation until they've had a flu test return negative. And once they've been cleared of the flu, then they can go to a shared room. And if the flu test comes back positive, then they stay in isolation. And so we worked with this startup company to develop they had built a platform to notify clinicians in real time of events. And so we worked to develop an algorithm that would, for admitted patients, check to see if the flu test, number one, had been ordered, if not, rectify that, and if it had been ordered, checking to see if it had come back, and notify the admitting office directly when those results were achieved. And so by doing this, and we recently published a paper on this, we were able to actually decrease the time to admitting the patient and also improve throughput throughout the emergency department as well as the hospital. And so I think the reason I share this example is we have to be thinking about the delivery mechanism of how we make AI actionable, and this provides a platform in which we can take any type of AI. I happen to show an example of just a rules-based algorithm, the simplest form of AI, but we can take even the most sophisticated forms of AI and get it to the right practitioner at the point of care at the right time to take action.
So let's stay with this. So I think as we think about implemented AI, there's this promise, but there's a significant series of sometimes unintended consequences. I learned about one example yesterday, which was an algorithm that did a particularly good job at predicting pneumonia. This was something that was going to replace the radiologist because it was so powerful in terms of the accuracy with which it predicted pneumonia. And in fact, it would ingest these images, these diagnostic images, and it would almost always give the right answer. And it was trained on a data set that was from the pneumonia clinic. And so what happened is the AI got smart and figured out how to cheat on the test. And it would look at the lower right-hand corner of the image where it said pneumonia clinic, and it would then figure out that the patient had pneumonia.
Oh, wow.
And so, and at which point it got adjusted. So it's just a point that, even the computers cheat sometimes. Like, well, why are you asking me? Of course, it just says it right at the bottom right corner. So, what are some of the unintended consequences? A shifting of work, the worry that people have about what AI is going to do to their particular job, and other headwinds that exist with AI. What are some of the barriers of AI?
So you just mentioned a big one, which is validation. And actually, if we're truly using in the real sense of the word AI, where you've got a system that is continuously learning and continuously updating, then we need to come up with the validation procedures to also match that real-time algorithm changes. And I think we are all still working to figure out what that would look like. And I just want to put this in perspective that I actually really came to fruition when I helped implement a laboratory information system. And it sort of gets to the law of large numbers. Many times when we're working on new, exciting technology or innovation projects, we're just trying to solve for 80% of the use case, right? If we can solve for 80%, we think we've succeeded. And the problem in healthcare is for many use cases in healthcare, that is simply not good enough. And so now imagine a test that has the correct answer 99.5% of the time. But when you start thinking about, let's take a laboratory test that might be performed 3 million times, and if that test is 99.5% correct, you still have a very large number of incorrect results. And if those are incorrectly diagnosing pneumonia, or maybe you're incorrectly diagnosing breast cancer, these become very significant. And so we truly need to validate and understand the test characteristics of these algorithms, and then educate our provider community and patients on how to apply them.
So it's true for any type of testing. We always talk about when you go to medical school or you do your residency, judicious use of testing requires that you know the sensitivity and the specificity of the test. The same thing is going to be true for how we use algorithms. What is software as a medical device? How is that going to work? What is the sensitivity and what is the specificity? Because each algorithm is going to have a different sensitivity and specificity, and we have to validate it, but we also have to teach providers how to use it, because there is no instant pudding and there is no magic bullet, and this is just simply another way to test to help make a decision, but nothing is going to be perfect and nothing's going to be 100% right.
I agree. I think that's fair.
I mean, I think from my perspective, I think the challenge is actually, I think we know where this is going. These things are going to become better and they will become the standard, but it's this cultural challenge and operational challenge of basically saying, okay, you pick any tool you want. If I am going to take this work away that you used to do, which was a burden, the only way that I can justify doing that is to ask you to do more of whatever the other thing is that we can't automate, and the blowback that we get. So I can't tell you in the last 2 months how many times we've implemented something where it automated some function of that person's job, which was great. It was not a desirable part of their job. But they came back and said, but does this mean that you now want me to see more people, or you now are trying to get rid of me, or you essentially you took away the part of my job where I didn't have to think. You took away the easy stuff. And all of those are really significant headwinds to the adoption of this, because at least the way we think about it is at least 20 or 30% of what everybody does in healthcare can be automated, but nobody's, at least where we're seeing it right now, no individual's job can be 100% automated. So everybody's getting a little piece taken off here or there, and productivity is really the only way we can justify that expenditure. And that tension is, we're starting to see it kind of bubble up now, especially in a tight labor market.
Yeah, that was my welcome to the NFL moment.
Yeah.
Was exactly that, where we were building our virtual health center and virtual primary care. It's not virtual, it's actual primary care and actual health. But our primary care physicians really let it slip. I'm not sure if that's the right word. That once in a while, when you have 20 minutes allocated for a hypertension recheck, that's a nice break for them. Even though it's completely disrespectful use of their brain and the patient's time, it was a break for them, and they would look forward to those. And when we took those away and put in a complicated COPD patient who was having chronic exacerbations, that was a burden, even though it was the same amount of time. So it really came down to this: have a conversation, have explicit expectations, and there has to be a win for both the clinician and the patient and the system, not just the system and the patient.
The other challenge, I think we're talking about full automation and replacement. I think a lot of what's being contemplated now is still decision support, where you're providing additional information or guidance to the clinician. And we still have not solved the problem of alert fatigue. And I think that the onslaught of algorithms that are coming are going to further contribute to that, right? We're still suffering from alert fatigue just from medication interactions, simple decision support within an EHR, and now we're about to take it to a new level. And so I think there's still a huge opportunity to improve. How are we delivering this information to the clinician? How can we make it actionable and filter out excess noise?
So it's this idea of that's being brought up of we're not trying to replace the worker. Right. We're trying to augment the people that are taking care of patients as much as possible. Are you finding other cultural type of barriers that you're running into?
I think the way I think about culture is, as Mike mentioned earlier, there are a lot of stakeholders in the space, and what is the readiness to embrace digital health for all these stakeholders? So if we start with consumers, our patients, I think they're ready for it. Every survey result I see, confirms that people's expectations are that in healthcare, that we will use better data, better digital tools to provide better access and more personalized experiences, just like they get from Netflix, just like they get from OpenTable. That's the type of experience that people are expecting. And so I think there's a readiness that we know is there from consumers. I don't know, we don't all know what that looks like, but we can apply analogous examples from other industries. On the provider side, we have a lot of work to do. I think, something like 65% of people, providers have a digital strategy, but fewer than 10% of those would say that culture is not a big issue and a big barrier to making that strategy work. And you know what they say about strategy and culture, right? That culture eats strategy for breakfast. And I think that that's really true. And so, a few of the things, we experience this every day in our work, and I think there are certain ingredients that we have to think about. One is just, comfort with talent acquisition and bringing on the right kind of talent. That's just a big shift, I think, that's happening in what we need to be successful in executing a digital strategy and doing the right things for patients and consumers. We've really got to advance that quite a bit and think about the way we train doctors and we train all of our professionals. I think that there's a different mindset and that we need, and some different skills that we need to be able to bring to bear in education. Everybody always talks about leadership, and of course it's critical. And I'm lucky that we have really strong, committed, progressive leadership at Ochsner. But that you got to have that, but you got to have buy-in really at all levels. And with people worried about how is this affecting me? And of course, it is affecting them some ways because we've got financial incentives and compensation structures that are maybe outdated and need to be updated. And so we're in this funny transition that can create barriers from some of the key stakeholders that you need their buy-in to be able to execute these things. And so, we're taking a hard look at how do we think about financial incentives? How do we think about, some of the structural pieces that we need to put in place to help support this culture of innovation? There's a natural tension to it. And, I think at the end of the day, we try to say, you need to be comfortable being uncomfortable, because that's just the lay of the land. But naturally, of course, people aren't. But that's sort of the narrative that we're pushing out. Just get there and marinate in it.
You can't ever expect someone to agree with you if it makes their life harder or costs them money, right? Two really simple things. The other is when we think about how do we deploy a tool, clinical decision support, whatever it is, there's some really basic guiding principles. One is there are no thou shalts, because if you say thou shalt to a group of providers, you will get the exact opposite. Right? So that doesn't work. The other is it has to be fewer clicks and not more clicks. It has to be the path of least resistance, and it has to be bulletproof right. So before we put something out there, those are the guiding principles. Can't make your job harder, can't cost you money, has to be bulletproof right, easier, not harder, fewer clicks, and not more clicks. Healthcare cannot be the last bastion of industry where deploying technology increases costs and makes it harder.
So taking a comment from the audience that wants to kind of drill into the patient experience side and how digital health can help with that. We're all trying to understand as people navigate outside of healthcare and enjoy a more digitalized and maybe transformed experience, walking into an Uber or ordering a table at a restaurant, and then they walk across the threshold into healthcare, jump into a time machine, go back 30 years, and then enjoy the technology that's there. So what are you thinking about? And we've talked about it a little bit already, but sort of more specifically on digital health and patient experience and where that goes forward.
maybe I'll just share an example. And this is an example that takes advantage of text messages, very simple technology that's well established, assuming we can get through the regulatory issues. We're using text messages for procedure preparation. So one example is, patients routinely have screening colonoscopies, which is seemingly unpleasant experience. We try to make it a little bit more pleasant. And so we start by simply texting an appointment reminder a few days before the procedure. Then on the morning of the procedure, we send another text with a link to our wayfinding directions so that the patient can get directions from their home direct to within the hospital to the colonoscopy center. Then they'll have their procedure. After their procedure is done, we text them another message where they can complete a patient experience survey. And then finally, a couple of days later, when the results are available from their colonoscopy, we'll text them a message indicating that they can log into the patient portal and see the results of this. The other component to this is when we text them the appointment reminder, we also text them instructions on what to expect with the actual colonoscopy procedure, including how to take the preparatory materials and frequently ask questions for the procedure. And what we've observed after implementing this program, we implemented this both at Brigham and Women's Hospital and at Massachusetts General Hospital. We saw first a 30% reduction in cancellation and no-show appointments. We've also seen an increase in prep quality, which has further resulted in decreased cancellations of colonoscopies or repeat procedures. And we've also seen incredible patient response and positive responses to this. So that's one simple example of taking advantage of text messages that we've actually seen a profound impact across our organization.
Excellent.
Yeah, I mean, to say that we took a sort of a broad look at this, and as I talked about earlier, we looked at capabilities we have to have and then tried to prioritize which of those are most impactful for that consumer sort of experience. And there's 68 different capabilities that we mapped, everything from how do you find what you're looking for in Google all the way to that sort of, everybody loves the billing experience. And prioritized how we were going to tackle each one of those over the course of the next 2 years. I mean, it is not going to happen overnight, but we view that this being sort of a systematic approach to taking out friction for consumers is the only way to start to be on par with an OpenTable or an Uber.
Yeah.
Yeah. And I would just add to that, I mean, I think friction is a big area, and there's lots of it, and there's also lots of fragmentation, where I think, from our personal experience as patients, we know that it just feels like you're out there alone and you don't necessarily know what to do. And so what we're finding is digital tools allow us to help support patients when they're not with us, and to do it in a way that is not invasive, in a way that they actually appreciate, and what they hear back is, I've never felt so supported. I feel like I have a guardian angel, those types of things. And we see, through validated measures, we can see that their activation's going up through the process, which we know it lifts all boats. So I think, in addition to kind of making it easier to access care, kind of creating a continuity that decreases that fragmentation is a huge opportunity that digital allows us to tap into.
We took an example actually from the car dealership that fixes my car. It was really simple, which was after I get my car fixed, I get an automated text message making sure everything's okay. And if they don't hear from me in a while, they text me and say, hey, Rich, we haven't heard from you in a while. Hope your car is okay. So we did the same thing. After a patient has an appointment, we text them, automated, just making sure everything's okay. If they reply, then we look at the reply, and sometimes we have a human call them. Really simplistic things that industry has figured out that we can easily adopt.
Well, we're running out of time. I wanted to thank the panel for their insight. I think a couple of things that we can take away as learning. So we talked about the fact that, the electronic health record era, was a really hard thing to do. And now the really, really hard thing actually begins as we kind of navigate into this next stage. We got our logo, we suck less. We understood how to capitalize the digital health in terms of little d and big H. We understand the component that there's a lot that goes on with health in between the visits and outside of the hospital and the clinic. We heard about the 68 capabilities that are that are existing, even just in patient experience alone, but thinking about things in terms of capabilities and being able to build the roadmap as a result of that. And when it came to like the top problems to look at, things around access, self-serve, triage, personalized medicine, keeping people at home and telemonitoring, understanding the hospital experience that we always want to make better, preventing readmission, making better decision tools as kind of some of the things that are useful to do. We've seen with AI and the application of AI in healthcare, the use of sort of more fundamental, basic capabilities like robotic process automation, but also ways to be able to surveil and identify patients that are at risk of decompensation, and a number of other things such as being able to provide patients chatbots instead of people when you're trying to scale those capabilities across a larger population of patients. Clearly, all these things don't come without a certain costs and trade-offs in terms of the fact that there's the degree to which an AI tool needs to be close to perfect is fairly important, or the degree to which we need to understand what the sensitivity and specificity of a particular tool is, just like any other tool. Maybe there are new roles in the provider space that will emerge in terms of people helping interpret what these algorithms are and when to appropriately apply them. It's clear to say this involves change, and with change always comes a significant impact on culture. We heard about the idea that we need to get good leadership, proper training, that the model is that we augment, don't necessarily replace, and that increasing cost and increasing work on a provider isn't a winning means to be able to approach the problem, and in fact, reducing clicks, make the path of least resistance the one that's actually the easiest for the process that you're looking for, and making sure that the process is bulletproof, even robust enough for the clinical care area. And when it came to patient experience, I think there are some basic things, texting patients, stealing from other industries that know how to do this, trying to make that experience less jagged as they insinuate themselves from home to the clinic, from clinic to the hospital, and then ideally back to the home. So with that, we have 25 seconds. It was a pleasure to have this panel. Please help me, join me in